meeting. Um, I hope everyone is doing well, and welcome again to our um, monthly case study review meeting. Today, we will be discussing case study not doing well in college. Um, Once again, I hope everyone can hear. The two texts that we will that I always use, and I need to mention them, are psychiatric case studies for advanced practice by Prendergast and Jackman, as well as case files review. Case file psychiatry by Toy and Clayman. Um, we'll go ahead and get started. Um, uh, this is case number 15. And let me see, I have some people that need to come in. Applications. Uh, I'm going to add a few more people to the meeting. And once again, if you have a question, you can go ahead and interrupt, but I will have a section at the end where people can ask questions. Alrighty, so let's go ahead and get started for the sake of time. Um, Not doing well in college. The identification of this individual. This is a 20-year-old single male who's a full-time college student living with his parents in a suburban middle-class community where he grew up. He is of Italian descent and he was raised in the Catholic faith, um, although he chooses to be an agnostic. He is self-referred at this time, and he's being evaluated at a private psychiatric practice. As far as the chief complaint, he states that I am struggling with anxiety and focus, and I also want to become more independent. Uh, History of present illness. The patient reports recognizing he has difficulties in various areas of his functioning. He states that he has considered himself to be very bright, but does not always feel sharp. He states, I am not doing as well as I can do. He states that his mind wanders. I get lost in my thoughts and I lose track of time. Um, Patient states that while completing simple tasks such as uh, being in the shower, cooking, anything that takes longer than 15 minutes, he'll get off track. Um, he states, uh, uh, oh, he recognizes that sometimes the thoughts are a waste of time and that it took years for him to realize his kind of daydreaming behavior. He states he experiences lost time with no recollection. He reports he tries to train his mind to focus deeply, uh, such as when driving, but sometimes he becomes over-focused on certain details or gets distracted and misses things, especially when he is tired. Um, the patient reports he has difficulty starting large tasks and he has trouble with envisioning the final project, particularly when it comes to his schoolwork. He believes he overanalyzes things, um, and uh, especially when writing, he then procrastinates and becomes very anxious. The act of trying to start a project makes him feel very anxious. In class, he listens to the professor, then he gets sidetracked from what is being said and is lost. He will study for an exam when I have no choice at the last minute. I force myself and I run out of time and I don't finish the material. So there's a significant amount of procrastination and waiting for the last minute to get things uh, done. The patient also reports being forgetful and losing information such as um, due dates. He additionally reports feeling anxious in social situations and When he needs to participate in class, he describes holding back socially in conversations because of a lack of confidence and not being sure if what he wants to say is going to be the right thing or relevant. The patient reports avoiding social situations in which he needs to participate in a small group discussion or meeting new people or attending parties or where he has to become the center of attention. He reports moderate to severe anxiety in social situations, such as when being observed, entering a room, expressing an opinion, or returning items in a store, or talking to people who are in authority. Past psychiatric history. Um, he presented at age 7 with a diagnosis of ADHD made by a psychiatrist uh, after demonstrating difficulties with attention, listening, adjusting to change, uh, possessing disruptive behaviors, and poor social skills. Uh, he was impulsive and had some attention seeking behaviors. And the onset of this was prior to kindergarten. He also was treated, he was treated at that time with Adderall, which led to persistent vocal tics that were further interfering with his functioning academically and socially. Most of the trials of the psychostimulants um, led to an increased tics and also obsessive thinking. Strattera seemed to be the best tolerated medication at this point, although it didn't produce the most robust control of the symptoms of the ADHD at the time. Prior to college, the patient made the conscientious decision to just stop taking any medications to see how he could function. Medical history. The patient has no known drug allergies. He has no head injury, seizures, infectious diseases, or any other major medical conditions. He's had one injury while engaging in sports that culminated in a cast to his right leg. History of drug or alcohol abuse. The patient denies any use of drugs or alcohol. Family history. The patient reports that his father had some difficulties as a child and adolescent with academics related to a lack of focus and keeping up with his studies. However, he was never evaluated, diagnosed, or treated. Several of the patient's cousins on his father's sides have some academic issues, although the details are not known. His mom, her family has a history of anxiety disorders. Personal history, perinatal. The patient was born full term. There were no complications or any developmental delays reported. Childhood academic performance was satisfactory, but he did require parental supervision to get his work done. He had friends in school and the neighborhood, and was active in recreational sports. In his adolescence, um, he continued with a close group of friends and select recreational sports. In adulthood, the patient currently has a long distance relationship with a young lady his age. He reports not seeing friends or engaging in college social life at this point. He spends his free time on a computer or playing video games. Trauma and abuse history. Trauma and abuse are denied by the patient. Now let's move on to his mental status examination. On appearance, the patient is well groomed and clothed appropriately for the climate. His posture demonstrates a level of comfort and openness to discussion. He is polite and pleasant in his attitude with the examiner. Behavior and psychomotor activity, the patient demonstrates appropriate eye contact, no hyperactivity, or any abnormal movement or verbal activity. Consciousness, he's alert. Orientation, he's oriented to person, place, and time. Memory, Um, Throughout the examination, the patient exhibits no deficits in recent, remote, or immediate uh, uh, memory, concentration, and attention. The patient has no deficits in concentration and attention during the examination. However, while completing a self assessment questionnaire on anxiety and ADHD, the patient worked slowly to complete as he thought through each item and asked for points of clarification while he considered each answer. The patient stated he felt unsure how to generalize his responses and that he was overanalyzing each item. Visual spatial ability. The patient demonstrated no deficits in visual spatial ability, abstract thought. The patient was able to provide good responses to abstraction, intellectual functioning. The patient speaks in an articulate manner and with excellent vocabulary and has an above average fund of knowledge. Speech and language, the patient had a normal rate and rhythm of his speech. Um, he is thoughtful in his responses. Perceptions, the patient denies any perceptual abnormalities. Thought processes, the patient does not, not does not demonstrate any abnormal thought process. As far as thought content, the patient reports experiencing anxious thoughts in social situations um, where he states he hesitates to speak up because of feelings of low self esteem and lack of confidence. He repeatedly rethinks what he should say and how he should behave when planning to attend um, a social situation, such as a party. The patient does not, however, identify any particular obsessive thoughts that might indicate a clear diagnosis of OCD. Um, suicidality or homicidality, the patient denies any suicidal or homicidal thoughts or tendencies. His mood is neutral with no history of significant mood alterations. However, of note is the patient's report that he sometimes feels down about his awareness that he is not functioning at his highest potential. Affect, the patient demonstrates affect that is congruent with mood and the content of the discussion here. Impulse control. There are no impulse control problems noted during the interview. However, patient reports poor impulse control related to playing video games when he needs to do chores or schoolwork. Judgment. There appeared to be no impairments in his judgment regarding societal boundaries, expectations. Um, Judgment is impaired related to his personal time management. Insight, the patient reports he has gained insights into his difficulties in functioning independently and socially in the past year um, while he was away at college and since returning home. His insight is above average. Reliability, the patient appears to be a reliable historian. All right. So we've gone through the history and the examination. Um, we'll now move on to formulating a diagnosis. So, which diagnosis or diagnoses should be considered? And we have two here based upon the history and based upon the exam. Um, First one is attention deficit hyperactivity disorder, predominantly inattentive type. And then the second diagnosis is social anxiety disorder. All right. And we do have a differential list here unspecified tic disorder, ADHD, possibly combined type, and OCD. We'll discuss those in a minute, but these are on the differential list. So let's dive into the first diagnosis um, ADHD inattentive type. So the diagnostic criteria this is a persistent pattern of inattention um, and or hyperactivity, impulsivity that occurs with functioning or development. Um, In the inattentive type, um, you need to meet a couple of these criteria, six or more of the following symptoms that have persisted for at least 6 months to a degree that is inconsistent with the developmental level and that negatively impacts directly on the social, academic, or occupational activities. Uh, Patient one, the patient often fails to give close attention or detail or makes careless mistakes in schoolwork or at work or during other activities. Two, they often have difficulty sustaining attention in tasks or play activities. Three, they often do not seem to listen when spoken to directly. Four, they often do not follow through on instructions and fail to finish their schoolwork. Five, they often have difficulty organizing tasks or activities. Six, they often avoid, dislike, or reluctant to engage in tasks that may require sustained mental effort. Six, they often lose things necessary for tasks or activities. Seven, they are easily distracted by extraneous stimuli. Eight, um, they are often forgetful in their daily activities. All right. Um, So let's go ahead and look at what criteria or what's the rationale for this diagnosis in this particular patient. Um, based upon the various components of the ADHD inattentive type diagnosis. The patient presented in childhood with ADHD, including difficulties with inattention, listening, adjusting to change, and disruptive behaviors, and poor social skills, such as being impulsive and having displaying attention-seeking behaviors in class. And this was noted prior to kindergarten. Um, but as a college student, he chose not to continue with the treatment and began to notice difficulties, including problems staying focused, completing his work or task, being easily distracted, and had difficulty paying attention. His presentation is primarily inattentive and not hyperactive at this time. So he's transformed from having the combined type to predominantly having the inattentive type of ADHD. Um, um, these difficulties exacerbate anxiety by the patient's report of avoiding or procrastinating, displaying avoidant or procrastinating behaviors, as he is aware of how he's struggling to manage his symptoms. In turn, feelings of diminished confidence have contributed to his social anxiety. Um, now let's move on to the secondary or um, additional diagnosis of social anxiety disorder that this patient has. This is a marked fear or anxiety about, social anxiety disorder is characterized by marked fear or anxiety about being in one or more social situations in which the individual is exposed to possible scrutiny by others. Examples include social interactions such as having a conversation, meeting unfamiliar people, being observed, or performing in front of others. Um, some of the characteristics or the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated by others, and thus they'll be humiliated or rejected or embarrassed. Um, these social situations almost always provoke fear or anxiety. The social situations are avoided and endured with intense fear or anxiety. The fear or anxiety is out of proportion to what the actual threat poses. The fear and anxiety or avoidance is persistent and typically lasts for 6 months or more. The fear, anxiety, or avoidance causes clinically significant distress or impairment. Um, The fear, anxiety, or avoidance is not attributable to any physiologic effects of the substance or a medical condition. And the fear and anxiety and avoidance are not better explained by the symptoms of another psychiatric mental disorder, such as panic attack or body dysmorphic syndrome or autism. Um, if another medical condition exists, um, the fear, anxiety, or avoidance is clearly unrelated or excessive uh, to that medical condition. So let's go over the rationale for this diagnosis of social anxiety disorder in this patient. The patient meets the criteria for social anxiety disorder because he reports feeling anxious in social situations and when he needs to participate in class. He describes holding back socially in conversation because of lack of confidence and not being sure if if what he wants to say is relevant. Patient reports avoiding situations in which he needs to participate in small group discussions, meeting new people, attending parties, or being the center of attention. He reports moderate to severe anxiety in social situations, such as when being observed, entering a room, expressing an opinion, uh, returning items to the store, or talking to people in authority. All right. So, you know, based upon this history, based upon the examination, he meets these two critical diagnoses: ADHD attentive type, and this is and he also has social anxiety disorder. All right. Uh, next task is to identify what tests or tools should be considered to help identify the correct diagnosis. Um, and the following tools were used in this particular patient. And although the reader or participant is evaluators encouraged to use other tools they consider relevant and valid within their own practice setting. Here, they use a self-report scale, which is the ADH, which is the adult ADHD self-report scale. It's a symptom checklist. Uh, I personally, in adults, um, would prefer to use a more objective test. We use the Moxo, MOXO, the Creos, and QB Tech. These are objective tests that are online that um, the patient can take, and it will score them or measure their attentive concentration and focusing abilities through various tasks, and it gives you a readout of whether the person has the diagnosis or not. Um, I tend to use objective tests more so than subjective because people may not be able to over-report symptoms, and you get a misdiagnosis. As far as the social anxiety disorder, there's the Leibowitz social anxiety scale that can be used uh, to um, determine or capture enough of the symptomatology to help you make a diagnosis of social anxiety disorder. Um, as far as the differential, unspecified tic disorder, um, ADHD combined type, and OCD, the patient's symptoms currently do not meet the criteria for any of these diagnoses, so they are just considered as part of the differential. And I'll stop right here. Does anyone have any questions or comments about um, the diagnosis, the differential, the tools that are used to aid in the diagnoses? All right. Uh, if there are no questions, we'll go on to formulating the treatment strategy. Which treatment strategy or which treatment would you prescribe, and what is the rationale? All right. So the author here, as far as psychopharmacology, um, they would recommend using Prozac, fluoxetine, 10 milligrams POQ day, with reassessment and dose titration as needed or required. The social anxiety will be treated first in this case with Prozac, followed by reassessment of symptoms, as studies show medications in the selective serotonin reuptake inhibitor category can be effective in the treatment of social anxiety disorder. Because anxiety can contribute to impaired concentration and focus, we should treat the anxiety disorder first. Once the patient is on Prozac for 4 to 8 weeks, we will reassess to determine the severity of the ADHD symptoms. If the ADHD symptoms are still present, uh, we will go ahead and plan a trial of Concerta 18 milligrams and titrate up to effectively treat the symptoms. Then reassess to monitor any onset of any motor or vocal tics or obsessive thinking based on the prior history in this patient, um, these prior side effects of the psychostimulants. So the take home point here is, if you do have a patient with ADHD and they may or may not have a comorbidity of an anxiety or mood disorder, but if they do, it's best to treat the anxiety or mood disorder initially and get that under control, as those comorbidities may contribute to attentional focus or concentrating or problems with concentration. So uh, the wise thing to do is to treat the attendant disorder or the additional disorder first. See if you can modulate or manage those symptoms that may contribute to focus, concentration, and then reevaluate after a sufficient trial of treating that additional diagnoses. Uh, Diagnostic tests, because all the routine lab results have been negative, no additional testing is ordered. Um, the patient will at least no blood test. We've done um, our scales um, to help support our diagnosis. The patient denied any history of any cardiac abnormalities with himself or a history of sudden death in his family, so no cardiac testing. EKG is indicated, um, and that's an important point. What I do with patients on stimulants, I do if they're going to be on the stimulants for ongoing. I do recommend an annual or biannual medical clearance from their primary care doctor. As people, as they age, have a tendency to develop cardiac problems that the stimulants and or even the other psychotropic medications could exacerbate. Referrals, no referrals are made as psychiatric mental health practitioner is conducting psychotherapy or medication management, and that's in a practice if you are skilled at providing psychotherapy. A lot of times, because of time constraints, you would refer the patient out to a colleague um, who does provide therapy, and you would continue communicating with them about your med management approach. Now, let's go over the types of psychotherapy that work in these cases. Supportive psychotherapy and cognitive behavioral therapy are both indicated in the treatment of social anxiety disorder and attention deficit disorder. Um, a combination of medication and therapy is considered to be more effective than one without the other. So, um, using supportive psychotherapy as well as CBT um, in these cases is important. Psychoeducation. Uh, the practitioner should educate the patient about ADHD as a disorder of executive function and self regulation, which affects time management and the management of emotional reactions. Uh, Further information can be found at add.org. Um, it's also recommended that this patient join the Attention Deficit Disorders Association, ADDA. This is a support organization of adults with ADHD, and one of ADDA's foci is college students, and they also have frequent webinars. So, getting, and then since the population that a lot that we see with adult onset ADHD is college students, um, um, having them participate with ADDA's website or programs would be important. Um, what standard guidelines would you use to treat or assess the patient? An example of a practice guideline for the treatment of patients with ADHD can be retrieved at www.aafp.org. Um, um, Although this guideline suggests starting treatment for the ADHD first, individuals should be evaluated for the severity of symptoms with the most distressing attributes and target them first with medication. So, once again, the take home point here is to always look for additional differential diagnoses and treat them before you start treating the ADHD symptoms. Um, um, because it would not be very prudent to treat an anxiety or or depressive disorder with psychostimulants alone. So you definitely want to rule out any additional diagnoses, get them treated, see how they affect the course of the attentional problem, and then address that. Um, of clinical note, ADHD is a disorder of self-regulation, which can lead to anxiety and or depression. One is likely to exacerbate the other if both disorders are present. Assessment should include careful exploration of patient history, behavior patterns, and functioning across all domains. Um, so just don't focus on the attentional symptoms. Look for other signs of psychopathology. Determining which disorder or symptom sets to target with medications. First is based on a discussion between the patient and a provider while education is being provided. Okay. Um, I'll stop right here real quickly. I got a couple of other things to present, but does anybody have any questions about this case and how it was managed or some of the things that they would do differently? Any questions? None at all. All right. Let me kind of dive into social anxiety disorder a little bit with some clinical pearls. Social anxiety disorder, one of the most common anxiety disorders with a 12-month prevalence of 7% in the general population. The onset usually occurs in late childhood and early adulthood, and the course is often chronic. So if you're going to see these cases or this diagnosis, it presents in late teen and college age individuals. Anxiety disorders have a high degree of comorbidity. So once again, you want to look and see what else may be going on. CBD, or cognitive behavioral therapy, a form of psychotherapy, is the treatment of choice for social phobia. The DSM-5 criteria for social anxiety disorder includes a duration criteria of at least 6 months or longer. So they need to have the symptoms for 6 months, and that goes as well for the ADHD. Um, Beta blockers such as propranolol and atenolol are the agents of choice for the short-term treatment of anxiety provoked by performance situations. SSRIs and NRIs may be useful for the longer-term management. Panic disorder can be a part of the presentation of social phobia, but this does not mean the individual has panic disorder. Generalized anxiety disorder patients tend to be anxious about a whole host of other worries other than just their social situation. So that's those two differentials, panic disorder and GAD. They're a little different. Now I'm going to go over some quick questions uh, regarding uh, social anxiety disorder. So, which of the following medications is commonly used in social anxiety that is associated with performance situations uh, shortly before exposure to a phobic stimulus? Atenolol, prazosin, Zoloft, Buspar, or clomipramine. You got five choices. The correct answer is atenolol. Beta adrenergic blocking agents such as atenolol and propranolol taken just before an event has been shown to be effective in treating anxiety associated with performance situations. Prazosin is used to treat nightmares associated with post-traumatic disorder. Sertraline and Buspar are therapeutic agents used for the treatment of anxiety disorders with regular daily dosing. Clomipramine is a tricyclic antidepressant that has been used in the treatment of long-term anxiety disorders, and particularly obsessive compulsive disorders. All right, next question on social anxiety disorder. Which of the following is an area of the brain which appears to be most closely related to anxiety based on functional imaging studies? You got the nucleus accumbens, the left prefrontal cortex, the pituitary gland, the amygdala, and the corpus callosum. These are areas of the brain. So, which one is associated with anxiety? The correct answer is uh, the amygdala. Functional and imaging studies, functional imaging studies have consistently showed the amygdala playing a central role in the area of anxiety. The amygdala is an almond-shaped mass of gray matter that is part of the limbic system. Answer A, the nucleus accumbens is considered to be the reward center of the brain. Answer B, the prefrontal cortex is thought to be associated with personality development. Answer C, the pituitary gland is a master endocrine gland that helps regulate many of the endocrine functions of the body. And answer E, corpus callosum allows signals from the two sides of the brain hemispheres to communicate. Okay, look at the third final question here. A 35-year-old man is being seen in the office because I'm afraid to give presentations and I'm going to lose my job. He stated that ever since he could remember, he has had a fear of speaking in public or being the center of attention. He feels awkward in social situations and does not know what to say. During these times, he reports that his heart races and he sweats profusely. Which of the following would be most effective in treating his condition? One, cognitive behavioral therapy. Two, transcranial magnetic stimulation. Three, haloperidol. Four, clozapine. Five, St. John's wort. The correct answer is CBT. This patient likely has social anxiety disorder based on the fear of speaking in public and in being in social situations. CBT is a specific psychotherapy that has the greatest and most accepted evidence base behind it supporting its utility in anxiety disorders. Although other treatments may be useful, this should be the psychotherapy of first choice in the area of anxiety. There are some emerging studies on the use of TMS, transcranial magnetic stimulation, for social anxiety disorder. However, this treatment modality has not been established as definitively efficacious. The other choices, haloperidol, clozapine, and St. John's wort, have shown no efficacy. Okay, we have finished the question and answer part. Are there any other questions or issues, concerns related to adult ADHD or social anxiety disorder?
I had a question about the atenolol.
Uh huh.
So what dose would we start with for an adult?
Oh, I'd have to look that up. Um, I would just off the top of my head, I would just start with the lowest dose, and because you don't know what other conditions these individuals may have,
Hmm.
um, whether asthma, something like that, and you always gotta be careful with using these beta blockers. Uh, uh, and if they have some already a hypotensive state or any cardiac, I would just ask about that. And to be honest, just like you get the medical clearance for using the psychostimulant in the ADHD, particularly in an adult, I would probably get the PCP to kind of give me an okay to use a beta blocker uh, in an adult with social anxiety disorder. Most of these kids, they're going to be teenagers and young folk or young adults, so it may not be a problem. But these days, you want to cover your butt. So I would get the PCP involved. But if if they need to use it short term and they seem pretty healthy, I would just start with the lowest dose and titrate upward. I don't think there's a standard intervention. And I would go to PDR.net for any recommendations if there's a milligram per kilogram dosing um, methodology involved.
Okay, so you said PDR.net.
Yeah, I use PDR.net.
Okay.
Yeah, and just plug in a atenolol, and they'll
Hmm.
tell you
Okay.
how to start the dosing. Um,
Okay, thank you. One more question, please.
uh-huh.
In regards to the ADD, what if we decide to use a non-stimulant like Strattera or Quellbri? I know
Uh-huh.
Quellbri, a lot of times you have to get a prior auth, but the Strattera we usually don't. So
Hmm.
for an adult, do we do the same? We just start at the lowest dose and titrate up?
Yeah, I would start at the low stuff. So I think Strattera is 18. That may be low. I think it goes to either to 20 to 25 or something. Um, yeah, I would start with those lower doses. Sometimes I'll start with I think it's a 25 milligram tablet. Once again, I just go to the PDR and I kind of base it off of that.
Okay.
But yeah, yeah. I always start low, go slow. I take that approach, and even though the patient may still be symptomatic or just be partial
Hmm.
remission, it's just safer uh,
Yeah.
to take that approach because you really don't know what's sitting in that chair, and they may not be telling you everything. They may have
So
some
would you
other.
follow up if because the lowest is 10 and it goes all the way to 100, I think it is. So if you started at 10, you would follow, yeah, it goes all the way up to 100. So you would follow up in what, 2 weeks to see if it's effective, or how much time should we give?
I would follow up in 2 weeks to see how they're tolerating, but the efficacy, it'll probably take about 4 to 6 weeks.
Okay.
You can wait the 4 to 6 weeks, but um, or you can see them in 2 weeks and do a bump up, just to see how if they're having any untoward effects to the medication, and then go
Hmm.
ahead and push it upward. But the standard dose is obviously going to be much more than that initial starting dose.
Okay. All right. Thank you.
Hmm. Um, Any other questions? Yeah, and I got a little twisted up. Yeah, I think the Vyvanse is the one that starts at what 18, one of those strange numbers, and then it goes up to 25. So uh um uh any other questions about ADHD or social anxiety disorder? All right. Well, if there are not any more questions, I'll go ahead and close this because I know everybody has to get back in clinic. But thank you for attending, and I'll let you know which um, case we're going to pick next month. If y'all have any recommendations, y'all can email us at info@aveniabehavioral.com. Okay. All right. Thank you, everyone, for attending. I'm going to go ahead and close out.